Friends, colleagues, it's a pleasure and an honor to welcome you and be able to bring this webinar in collaboration with the section of the Oncological section of Urology. My name's John Aning. I will be chairing the session, but I'm joined by esteemed colleagues Benjamin Pradère, Jens Bedke, and Nick James. And today we're going to be focusing in on bladder cancer and some of the key data that's been presented at ESMO. We're not only fortunate to have experts in the field, but we've got key authors on the papers that were presented. So this is a real opportunity to go into the studies in depth, talk about the clinical application, and a chance for you to ask questions also. So please do put your questions in the Q&A, and we'll try to get through as many of them as possible. So with no further ado, I'd like to hand over to Dr. Benjamin Pradère. He is chief of the bladder cancer section of UROOnc education, and it's a real pleasure to have him here to talk about the summarized 4 components of the study. Thank you, Benjamin.
Thank you very much, John. It's a pleasure to be here, and it's a great honor to present you today the data of Sunrise 4 that has been presented by Andrea Nicki last weeks in Berlin during ESMO. The trial that has been presented in Berlin is a Sunrise 4 study. You may have already heard about it, and we have presented the primary analysis and the biomarker results regarding this trial that was a neoadjuvant gemcitabine intravesical system that we called TAR-200, not we call GEM-IDRS, plus sertralimab or sertralimab alone in patients with muscle-invasive bladder cancer. You know, the Sunrise program is a lot of different studies on bladder cancer, and this one is focusing on muscle-invasive bladder cancer. I have some conflict of interest. I'm an advisory board for G&G, and I'm a part of the co-authors for Sunrise 4. So we know that we have still a lot of unmet needs when we talk about patients with MIBC and who are refusing or ineligible to cisplatin chemotherapy. Although it's the standard of care, we have up to 50% of patients that will be ineligible or will refuse cisplatin. And nevertheless, we know that at the time of radical cystectomy, the pathological stage will be the best prognostic factor for survival. And when we look at the pathological complete response rate, which is one of the most important one, when we just do a radical cystectomy with neoadjuvant therapy, you have 10 to 12% of complete response. When we use neoadjuvant chemotherapy, it goes from 26 to up to 40% of patients who have a complete response. And we have nearly the same results when we use neoadjuvant chemo checkpoint inhibitors with 31 to 37%. So we know that patients who have received neoadjuvant chemotherapy and have a complete response rate, they have a dramatic lower risk of death, 50% less, and 80% lower risk of recurrences. So we know that it's very important, and we are still looking for effective and more tolerable drugs that can be options for this patient who can't receive cisplatin-based chemotherapy. That's why the GEM-IDRS or TAR-200 has been also developed, and there was a phase 1 trial that's showing that there is a benefit in MIBC, and that's how came up the idea of using this GEM-IDRS with a combination of sertralimab, which is an anti-PD-1, in the setting of neoadjuvant in MIBC. The trial itself is a multi-center open label, and it's parallel cohort phase 2 trial, which means that we can't completely compare cohort 1 and cohort 2. It's not based for that. In cohort 1, patients receive a GEM-IDRS TAR-200 plus the sertralimab for 12 weeks. And in cohort 2, they just received the checkpoint inhibitors, the sertralimab, the anti-PD-1. And patients were so affected to cohort 1 or to cohort 2, and they were all T2, T4, N0, M0, MIBC. Then the patient received radical cystectomy and were followed. The primary endpoint in that patients were the complete response rate after radical cystectomy. And among the exploratory endpoint, there was the biomarkers that has been presented and I will show you today, and also the secondary endpoints, recurrence-free survival and the safety. So this study has been presented, and that was the primary analysis and the exploratory on the biomarkers. When you look at the table of patient characteristics of Sunrise-4, it's basically something that we are used to in this kind of trials, in this setting of MIBC, cisplatin ineligible or refusing it. We had quite a high rate of T2 patients with around 78 to 85% according to the cohort who were T2. So many of our patients were T2. There's a little difference in PD-L1 status, but the number of patients who had a PD-L1 evaluation was very low, so it's very hard to get anything from it. And when you look at the reason for not receiving cisplatin-based chemotherapy, 45% were ineligible and 54% were refusing it in the cohort 1, which is a gemcitabine cetralimab. Then let's look at the results. When you look at the results regarding efficacy, I remind you the primary endpoint was the complete response at cystectomy. And here we see that the pathological complete response rate was higher and the RFS was longer in the cohort 1, which is a cohort receiving GEM-IDRS, the TAR-200 plus cetralimab. The pathological complete response rate was 38% with an overall response of over 50%, 53% exactly. In the cetralimab cohort, only the anti-PD-1, 28% of complete response rate. At 12 months, the recurrence-free survival was 77% for the patient receiving GEM-IDRS plus cetralimab, the TAR-200 plus cetralimab, compared to in the cohort 2, only 64% of RFS at 12 months. Regarding the safety, there were no new safety signals for GEM-IDRS or for cetralimab or for the combination of both of them. Regarding the adverse events of GEM-IDRS, this is very common adverse events, things that we see usually with other drugs that are intravesical, so nothing very specific. And regarding cetralimab, there were no differences compared to other anti-PD-1 that we know in this setting. When we look at the biomarker part, it's interesting because we have looked at UTDNA as well as ctDNA. When you look at UTDNA, so coming from the urine, we were assessing it at baseline and at 12 weeks, so before the radical cystectomy. And we see that there is a reduce of UTDNA MRD from 12 weeks to the baseline. Indeed, at baseline, there were most of the patients were UTDNA positive, and at 12 weeks, only 52% were positive. But there were no differences according to visibly complete TURBT or visibly incomplete TURBT. It means that at baseline, the UTDNA, either you have completely removed the tumor or not, there were the same rates of UTDNA positive patients. That's an interesting point to analyze. So basically, the fact that the surgeon saw that they removed everything was not enough, and the UTDNA was still positive in most of the patients. When you look at the UTDNA negative at status at 12 weeks, so after the treatment, we show that it has been associated with a pathological complete response rate. Indeed, patients who achieved pathological complete response rate were UTDNA negative in 81% of the cases. And we show on the ROC curve that basically there is a great correlation between the UTDNA at 12 weeks and the pathological complete response rate. When you look at the UTDNA clearance from baseline to week 12, it was also associated with a pathological complete response. So, for example, when you look at it, you see that there was 80% of patients who were UTDNA positive at baseline, and they achieved a pathological complete response rate and had a UTDNA clearance. So most of the people that were UTDNA positive have a pathological complete response rate, had a great UTDNA clearance at 12 weeks. And when we look at the ctDNA negative status, which is also something that we are more and more, and we will use more and more in the next coming months and years, the ctDNA negative status at baseline and at week 12 was also associated with a longer recurrence-free survival. So patients with ctDNA negative had better recurrence-free survival. In conclusion, this is a primary analysis of the Sunrise 4 trial. We were assessing neoadjuvant GEM-IDRS, the TAR-200 plus sertralimab. And we show a high pathological complete response rate, similar to other ones, with 38% of complete response, and a 12-month recurrence-free survival of 77%. Which support that the combination of IV systemic sertralimab plus a local treatment like GEM-IDRS needs to be more investigated in the future for treating MIBC. We've seen that sertralimab monotherapy had a complete response rate that was already known, with around 28%, with RFS that is at 64% at 12 months. There were no difference in terms of safety compared to other trials. And I think the most important was also the exploratory analysis of UTDNA and ctDNA that support to use this kind of biomarker as predictive biomarker for residual disease after a treatment with a neoadjuvant chemotherapy. When we see that 82% of our patients with a visibly complete TURBT were still UTDNA positive, it means a lot in terms of assessment before going to neoadjuvant therapy. And the UTDNA status is a potential marker for local disease because it was very well associated with pathological complete response rate. Thank you.
Thank you, Benjamin. Excellent presentation, but also just some really interesting food for thought there. So can I ask you first a practical question, because many of our audience will be wondering about the experience of the TAR-200, administering it in clinical practice in this patient population. So first question, just as a urologist and doing this, any difficulties, any things to watch out for, anything that you gained insight into from the study?
No, I would say TAR-200, so we have to call it GEM-IDRS now, but
Yep.
the GEM-IDRS is basically something that every single urologist are able to give to their patients. It's basically putting a catheter into the bladder. We do it every day, and dropping inside the system itself in the bladder, which works like a tea bag. And the adverse events that patient may have in this setting are basically what we are dealing with every day with double G stent or even with BCG. So there is no real difficulties regarding this, I believe. Maybe the most important is, of course, and it's exactly the same when we use any other intravesical treatment, it's to not give the treatment too early after the resection, especially if you have a huge tumor, MIBC, where you have been very deep into the bladder wall. I believe you have to wait a bit before starting the treatment. Otherwise, the toxicity of the local administration of chemotherapy might be a bit too difficult for the patient, and he will have more overactive bladders and irritative symptoms. Otherwise, it's really something that everyone can, at least all the urologists are able to handle.
Okay, thank you. And please keep putting your questions in the chat. I'm going to start asking a couple. So for a cisplatin ineligible CT2N0 patient who's refusing standard neoadjuvant chemotherapy, how would you counsel them on this strategy versus immediate cystectomy or bladder-sparing chemoradiation? And that's a question from a colleague, based on the data you have so far.
So I think chemo radiation. So if we don't talk about the use of gemcitabine plus cetralimab, I think in patients that are cisplatin ineligible, if the patient are fit for TMT, this is a great option. I mean, the option of trimodal therapy has become a normal option next to cystectomy in 2025 in the EU guidelines. So I think we have to really like embrace a new way to talk with our patient and the way we discuss and propose trimodal therapy. So I really look forward for the next months and years with the new development of drugs that are giving more complete response to these patients, because I think it's not only the question of is cis ineligible, should I do radical cystectomy or TMT? I think today the debate is nearly closed. We have to propose both of them and discuss it. Of course, some patients are really not good candidates for TMT, and we need to take care of that. There is a learning curve for it. But that's probably not the case today to discuss. But I think the other question behind is that if we have a good complete response rate, we would get a lot of patients coming now and saying, I don't want to to receive a cystectomy anymore. And that's why I think if I want to make a link with a presentation I did, this is where this biomarker, UTDNA, ctDNA, will be more and more important to really get a better advice on how to assess first the clinical complete response after neoadjuvant therapy, to propose a bladder sparing strategy for these patients. So this is probably what I get the most from the trial we have here. Gemcitabine plus systemic therapy works well, but the most attractive part, in my opinion, as a scientist as well, is also these biomarkers strategies.
I agree with you. The biomarker is super exciting, and I can see Professor Nick James wants to come in on the conversation as well. So, Nick, do you have some comments?
So fantastic! It's fantastic work, and I think the biomarker work is particularly important there, because I think my take on it broadly, and I must say, is that urinary DNA is telling you about the urinary tract very sensitively as to whether there's tumor there or not, and circulating tumor DNA is telling you about whether you've got metastatic disease or not, and neoadjuvant therapy. And I think that's getting clearer and clearer. But on the trimodality therapy thing, so as with most things, the British approach is different to the rest of Europe. So we've been doing bladder preservation as the majority treatment for bladder cancer for my entire career, which is now quite long. And so I think there's two separate populations here. There's patients who are older and really not very fit at all that we've always offered radiotherapy to, and would now offer chemoradiation to. And there's younger patients where you've got the cystectomy, and the spectrum kind of gradually, as you go from one end of the spectrum to the other, the question gets different. But a lot of what is written about people being unsuitable for TMT is based on kind of American selection criteria, but like completely debulked and things like this, which we would say are not criteria at all. They're just prognostic factors. Completely versus completely debulked is just prognostic, just as it is for cystectomy. It's just essentially T2 versus T3, which is kind of the point I wanted to make, really, is that you didn't specify what you meant by criteria for TMT, but the UK approach is we don't really care whether you've been debulked or even attempted at debulked. And I think with more and more active systemic therapy, it's going to become much, much less relevant. As the EB303 trial showed, you'll get spectacular complete response rates and really not very good cystectomy candidates. So it really makes the question of debulking kind of redundant.
I think, Nick, you raised some really important points there. And Benjamin, from your presentation, I certainly took this away, that when the urologists feel that they have a complete resection, there is still UTDNA present. And I think our concepts about how we think about the operations we do and the disease we're treating, they'll have to change with our modern diagnostic paradigm, which isn't just going to be the operation. So would you like to close maybe with a comment on that? And you know, do you use UTDNA in your practice at the moment?
Well, I wish I could use UTDNA in my practice, but I'm in France and it's too expensive. I can't use it on a daily basis. Unfortunately, it's just for trials. But I mean, you made the conclusion. I think surgery is a backbone of a strategy of bladder sparing. If you want to have a good bladder sparing strategy, you need a really good TURBT, but we can't rely on the aspect that we have at the end of the TURBT. So I think it's very important for the next years in the way we're going to go for bladder sparing strategy to be sure that you have, of course, a complete TURBT, but using all the new tools that we have, the UTDNA, MRI, and Nick will talk about MRI, of course, but we have to really use all a combination of different tools to get the best clinical complete response, the famous clinical complete response that also Galsky have tried to develop in his trial, in the phase 2 trial with Nivo Gemcis. And I think it's a way to go. Surgery will not be enough to decide of complete response, but basically the combination will be the future for it.
Well, look, Benjamin, thank you so much for joining us this evening.
Yeah.
It's great to have you with us. At this point, what I'm going to do is I'll hand over to Nick James. We'll keep the conversation going in the Q&A sessions, but thank you, Benjamin. Professor Nick James from the ICR, it would be great to have you speak with us about Bladder Path.
Thank you very much. There's a few things I think maybe will change. And so I'm going to start talking about breast cancer. And just very briefly, going to make this point. This is mortality rates from breast cancer. And those of you who are surgeons and study surgical history will know that the Halsted radical mastectomy was developed in the 19th century and then was expanded on in terms of the degree of radicalness, so that women underwent unbelievably mutilating operations through the 50s, 60s, 70s, 80s. And then all of a sudden that stopped. And at the same time that it stopped, mortality rates started dropping. And the reason that it dropped was that we went from a sort of surgery-only approach to a multimodality approach with drugs. And the drugs got better and better and better, and integration of radiotherapy got better and better. So now organ preservation is the norm in breast cancer, not radical surgery. And the surgery's gone from this sort of thing on the left to what you see on the right. And the reason it's gone that way is because the drug treatments have got better. And we've been kind of there for quite a long time, to be honest, with bladder cancer, but we've seen an absolute explosion of exciting new agents in the last 5 years. So we really, really need to rethink what we're doing with bladder cancer. And in parallel with the new drugs, as we've just seen very nicely in the last presentation, not only is new ways of delivering the drugs, but new ways of monitoring them with circulating tumor DNA. And this just means we just need to rethink everything we do. So MRI and bladder cancer, you get great pictures. This is from our Bladder Path paper published in JCO earlier on this year. You can very clearly see the difference between the T3 tumor below and the TA tumor above. You've lost the plane here, whereas you still have a plane there, for example, with the TA tumor. And you can see it with the various different imaging sequences. So one of the things that comes up in the context of this is if we're not going to do a full fat TURBT, is do you leave the TURBT for histology? And I'll just point out that for most cancers, we're very happy with a biopsy. We don't need to take scoops of tumor out in grams and grams. We're happy with a needle core in the prostate, for example. So arguably, you could just do this with flexible histology, flexible cytology. But also, again, as we've just heard, I mean, we've heard about using urinary tumor DNA for monitoring as a sort of binary biomarker, present or absent. You can do much more to it than that. This is data from our own group in Birmingham, looking at sequencing the tumor DNA to identify which mutations are present or not. And you'll see there's a very high level of concordance between the urinary free DNA, the pellet from the urine sample, and the tumor. We sequenced about 1,000 patients' tumors and had matching urine pellets from them. So you've got a very high degree of concordance across a whole range of mutations. So you don't need to take grams and grams of tumor to get a complete mutational profile of the tumor, for example. You've just seen this slide, so I don't need to go through it again, but it just makes the point that presence or absence of urinary tumor DNA is actually a biomarker both for presence of tumor and for response. There are various ways of doing this. And in fact, the way that we're doing it in our forthcoming trials uses a tumor agnostic panel, which is actually quite cheap. It's about £400 a sample, which is down at the level of a cystoscopy. I also briefly made a point in the Q&A just now around circulating tumor DNA, and there's loads and loads of data on this. I just highlight this from my friend and colleague Tom Powell's from Barts, who presented INVIGO 011, and this was comparing ctDNA negative to ctDNA positive with plus or minus atezo. And so for the ctDNA positives, what we see is that you've got a high relapse rate and it's reduced by atezo. Sorry, just lost the slide here. But basically, for the ctDNA negatives, the relapse rate was really low, and they'd previously shown that atezo didn't do anything in that group. So we've got a lot of exciting emerging data on liquid biomarkers, and we've got a tool that we can use, MRI, actually quite an old tool. So if you think about the pathway, you've got two things. You've got MIBC, you want to identify it, and then you want to fast track them to URBT, which I agree needs to be done well and properly because it's a cure. But for MIBC, I don't think it's a very good staging tool. We can do better. If you're going to do a TURBT, you need to tailor it to what you want to know. Do you need to debulk sometimes? Mostly, I don't think you do. Do you need to assess CIS? Yes, you do. If you're going to want to do surgery or considering doing bladder preservation, you don't want to preserve the bladder with lots of CIS because you're going to lose it in the end. Got a lot of problems like bleeding or whatever, you might need to do a TURBT. You don't need to do a one-size-fits-all, resect everybody down to muscle for everything. Why would you do that if you're going to do a cystectomy the following week? It's pointless. What you want to do is get enough diagnostic information to then make the right definitive decision. So we have an MRI system designed by actually a number of my Bladder Path co-authors, including Jim Casso and Shyster Hafiz, very similar to PIRAD. So it's something your radiologists are already very familiar with. So the background to Bladder Path is that, just skipping through some of this, is that it's not really changed in a century, and neither have bladder cancer outcomes until very recently for metastatic disease because of new drugs and stuff. But also for most cancer sites, imaging and biopsy is the standard of care for staging. The study design of Bladder Path was that it was an open label where we simply introduced MRI before TURBT for patients who had suspected muscle-invasive bladder cancer. So not for all the patients, just for the ones we thought might be muscle-invasive. And we just basically included anybody with a bladder mass in the hematuria clinic, randomized 1-to-1 to the standard of care pathway versus the MRI pathway, only for the patients who we thought might have muscle-invasive disease, which is about half of the total. We initially hoped that the MRI pathway would evolve to no TURBT at all and a biopsy, but actually, because clinicians could decide what they thought needed to happen next, it turned out that virtually everybody got a TURBT on the MRI pathway as well. It's something that's important to remember looking at the next data. So it's quite a complicated looking thing because we asked patients, the surgeons, to split the patients into probable MIBC and possible muscle invasive. On the control arm, everybody got the TURBT because that's the standard of care, and then that separates them. On the research arm, the probable non-muscle invasives also went straight to TURBT because that's their treatment, but the possible MIBCs got an MRI, which then separated them into MIBC or NMIBC with downstream treatment as appropriate. So we had 3 stages: feasibility, intermediate, which was aiming to show that we reduced the time to definitive treatment for MIBC. and a final stage, which we presented at ESMO 2 weeks ago, on progression-free and overall survival. So the first part of this was that we would actually accurately identify MIBC on the flexi, and we provided a whole load of charts for theatre and so on to guide people on what we were expecting to look for, and it worked. So basically, around about half of the patients on both pathways were identified as almost certainly MIBC, and basically, if you thought it was pretty much MIBC, you were pretty much always right. So we had a couple of MIBCs in patients that the surgeons were very confident on flexi were non-muscle invasive. For the other half, roughly, where you thought there might be muscle invasive disease, it was about half of them overall, just a little bit under half on the control arm, and slightly over half on the experimental arm, were thought to be possibly muscle invasive, and it splits kind of 50-50. I'll come back to these numbers down the line. So the data we just presented was the final update on the trial. So the feasibility stage we published, it's feasible, and this was in a multi-center setting with 15 sites. The intermediate stage was reduction of time to treatment, the target being 30 days. We published 2 papers on this, the most recent being in JCO a few months ago. And what this showed was that time to definitive treatment came down by more than our target. The target was 30 days, it came down by 45 days. This is time to cystectomy, radiotherapy, or chemotherapy for your MIBC on the control arm versus the experimental arm. Drilling down into this a bit further, so that's the curve I just showed you. We also had time to correct treatment for all patients, so we didn't harm the treatment for the by improving one group, we didn't worsen another group. The MRI group still did better, the red group here. And if we look specifically at the NMIBCs, we had no impact. However, there is this group here where the MRI thought they were MIBC, who actually went and had a cystectomy and had non-muscle invasive bladder cancer. Now, this was clearly a concern for us. So in this presentation and paper, we've gone into that a bit further. So it turned out that nobody had a cystectomy. So these are the reasons why people had a TURBT having had an MRI. And you can see there's a range of reasons. Lack of confidence, histological variance, check for CIS, debulk prior to radical therapy, radiotherapy in this case. Not all surgeons agree with the view I've just expressed, and so on. But more importantly, of the ones who had cystectomies, they were equally distributed between the control and the experimental arm, and nobody had a cystectomy without having a TURBT first. So we're very confident that although patients were getting cystectomies for non-muscle invasive disease, they were not getting them by mistake. People knew what they were operating on when they did the cystectomy. So that just summarizes that. So the final thing was, what did adding this do to the clinical outcomes down the line? Because the other way of looking at this is, if we put the patients in the wrong category, we potentially harm the long-term outcome. So if we label muscle invasive patients non-muscle invasive or whatever, you're going to get your outcomes are going to be skewed down the line. That's the proof of the pudding, as it were. So in order to do that, we had to ascertain causes of death. And I think it's worth dwelling on this a bit, because this is pretty typical for bladder cancer. So the trial was recruiting through COVID, and so COVID up as a cause of death, but also more importantly, cardiorespiratory causes do as well. These patients are lifelong smokers; they die of smoking-related diseases. They also die of other smoking-related cancers, and from other cancers, simply because these are people in their 70s and beyond. So giving just under half the deaths, about 40% of the deaths, were due to non-bladder cancer causes. And this is pretty typical of this population. But very strikingly, we've got a big imbalance in bladder cancer deaths. So what's happening here? So we looked at progression-free survival, and this is pretty underpowered, I have to stress, because we had to stop the trial recruitment because of COVID. But nonetheless, the hazard ratio is less than 1, but the confidence is across 1. So it's not a statistically significant answer, but the trend is in the direction that favors the MRI. When we break it down, again, you can see a big difference between the non-muscle invasives and the muscle invasives, as you'd expect, but the numbers are then tiny, so we can't really conclude very much about the impact of MRI. However, when we look at bladder cancer specific survival, we now have a statistically significant difference in favor of the MRI pathway. So getting people to treatment faster without doing a full fat TURBT is actually improving their bladder cancer specific survival. And I would point out this hazard ratio is bigger than the hazard ratio in EB303, that is driven substantially by the effect on muscle invasive outcomes. But also you can see there's a difference in the non-muscle invasive outcomes, also in favor of the MRI pathway. Obviously, this is all hugely underpowered, but none of the changes go in favor of the control arm. If we look at overall survival, I've already shown you this is diluted by deaths from other causes. Hazard ratio, again, significantly less than 1, but crosses 1. But again, you can see we've got a very clear separation in the muscle invasive cohort. So overall, our conclusions from this was that there are strong trends to improvement in all the key trial metrics in favor of adding the MRI. So time to treatment, feasibility, we previously shown, but now in terms of clinical outcomes, they all trend in favor of adding the MRI. There's no evidence of whatsoever detriment on outcomes, including inappropriate cystectomies using the MRI-based pathway. And there's a statistically significant improvement in bladder cancer specific survival of substantial magnitude. So my last slide just loops back to Benjamin's presentation. You can envisage a completely different pathway where we have an initial assessment with flexible cystoscopy, MRI, biopsy, and liquid biomarkers. And these will profile the tumor and give you a lot of prognostic information as well, which I haven't had time to go into. You may want to do a TURBT for staging purposes to look at ureters, look at urethra, look at CIS, maybe confirm you've got muscle invasion if you're not sure about it, but you don't need to scoop the whole thing out. That then allows you also, and again, I haven't had time to go into this in this talk, to use the MRI as a response assessment tool alongside your liquid biomarkers, which Benjamin has already showed work really well. And that gives you a really good base for doing bladder preservation with or without chemoradiation. Now, I think if you're getting really high CR rates to EV pembo and stuff, you may well not want to do the chemo RT bit either. We also know from a lot of studies, including our own, that surgical salvage is completely feasible and safe on the back of all the various systemic therapies that are now in trials and on the back of radiation. And the new systemic therapies are offering loads of really interesting opportunities.
So look, thank you very much, Nick. Jens, Benjamin, I'm going to bring you in shortly. Actually, I really want to get your insights in your practice as well as those of the audience. But Nick, if I start just in the UK, we have a really big problem. The wait to get to cystectomy or definitive treatment is about 144 days at best. It can be almost a year.
Yes.
What you've presented is that clearly the MRI scan has had an influence in the pathway, but could it also be assumed that the focus that the MRI brings to the pathway brings higher quality care? Some might say that. What's your answer?
I almost certainly it does. So within our own network, we've partially adopted it. So places like St. George's down the road from us, where they do more diagnostics than we do at the Marsden, say they're not really doing debulking TURBTs anymore. They're doing MRIs. They're just making a decision. So the patients are having TURBTs, but they're not the same. In that they're much more limited, and we're not at all bothered in our MDT now whether there's muscle or not in the specimen if the MRI shows invasion. If you're going to go to cystectomy, why would you care, really? So it allows you to do simpler, quicker procedures. It allows the right surgeon to do the right operation rather than a one-size-fits-all. Because we know having everybody debulked by whoever happens to be in theatre that day results in a lot of re-resections. So it's very inefficient on theatre time. It's very bad for patient care and quality of patient care. So we think that, you're right, it improves quality. I think the other thing I would say is that these delays are inherent in all healthcare systems. Yeah,
I'm only going to interrupt you because I want to bring Ben in and Jens in to talk about their healthcare systems for that reason, so you can have an opportunity to comment. So, I mean, Benjamin, in France, how does this sit? What are your thoughts? And do you have any comments that you'd make for Nick or questions?
I have thousands of questions for Nick, but I will try to make it brief. I think in UK there is this possibility to get an MRI very easily, but the burden of MRI, for example, in France is a problem. We don't have access to MRI as you can get in the NHS or in UK in general. But we have a faster pathway for patient overall to get cystectomy. So there is really a balance, and I think that the question raising regarding the healthcare system and how we can implement MRI to help your patient pathway adapted to the healthcare system is definitely a way to do it. I wish I could give to all my patients an MRI before I start the surgery, the TURBT. I have more access to the surgery than to MRI, basically. So that's really the question on that. I have two questions for Nick. The first one is, so Nick, I'm not a urologist in UK, and let's say I'm not in France, but how would you convince me that I need to implement MRI on a daily basis for my patient and not going to TURBT? If you have 1 minute. And my second question, so you can go straight forward, otherwise I know you're going to talk for 2 minutes. My second question is, do you think MRI, the future of MRI is to stay, is to be combined with biomarker, or do you think biomarker might be better than MRI?
So I think the first thing, so one of the reasons we designed the trial as we did with the initial Likert scale is that you only need to do the MRIs on the patients who you think might be muscle invasive. So that's, say, half for the sake of argument. And I don't know if you're doing MRIs before you do prostate biopsies, but you will be doing 30 MRIs for prostates for every one that you do for bladder. So it's not a big increase in your workload to add to this. And also, there's recent data published showing that you only need to do biparametric MRIs for your prostates. So you've instantly doubled your prostate MRI capacity if you ditch all the contrast sequences. So there is a way to creating the capacity. It then goes through the same MDTs, same radiologists, same urologists, same everybody. You're very familiar with looking at MRIs because you're looking at the prostates all the time. It's the same issue. The second question, I think the UTDNA is telling you something different. It's telling you that there's tumor in your urinary tract. It's not telling you if it's invasive or not. So the MRI will tell you whether it's invasive or not. So they're complementary. I think we're going to be using both.
Okay, thank you both. Same as you, Benjamin. I could talk for hours, and this is really great to have all of you guys on the call. Jens, can you give your perspectives from your centre and any thoughts, please?
Of course, Jonathan. Nick, I think you must be congratulated to perform this excellent trial, which is very innovative, and just doing that is such a diagnostic approach, which is really, it's not difficult. And then you had the COVID times. I can imagine that this was very, very hard work to do. Well, but on the other hand, I think it's maybe very related to the UK system. So I agree with Benjamin that access to surgery, TURBT, early access to TURBT is not an issue, not at my center, not I think in Germany at all. So we have more a bottleneck in the MRI, to be honest. So I'm quite surprised if I could send some patients to the UK for a fast and quick MRI scan, either of prostate or of bladder, what I learned, yeah. I think on the other hand, I mean, you proved us that that the time to definite treatment is reduced by the 30 days. EV303, just to correct you, did not show bladder cancer specific survival, so the hazard ratios cannot be compared. And the overall survival was not different between the arms. And I think at the end, patients, and you mentioned that, having a risk for smoking-associated cancer, dying of other disease than bladder cancer, and there's no overall survival benefit, just numerical benefit, but not statistically. Well, what is the impact on the long run here?
So yeah, I mean, the healthcare system thing is obviously what it is, but inherent in the TURBT pathway is that you end up re-resecting people because you don't get muscle and so on. So I think if you talk to, and yes, of course, all healthcare systems differ, but we've done in the papers that we've written, we do a review of delays in healthcare systems, and it's not a UK specific thing. Because if you're having, like in America, office urologists doing one bit and another urologist doing the resection and another urologist doing the cystectomy, you've got pathways with multiple steps in, and sometimes the steps get repeated. So the delays are not specific to the UK system. They are inherent in the pathway that depends on completeness of muscle resection and so on. And as we've seen with prostate, once you start doing them, it's just obvious that it changes your management. You know, we changed management for prostate very comprehensively in the UK without ever showing it improved outcomes. We were just very confident you're making better decisions. So we've shown that you make better decisions, but I accept that the outcomes data are not that robust. It's quite a small trial, but nonetheless, the outcomes data are all in favour of doing MRI.
Okay, and Nick, I'm going to ask you one last quick question, just from the chat from the audience. Any problems from an oncological point of view offering neoadjuvant systemic therapies based on the fact that you don't have muscle in the sample?
So we were very surprised that right from the get-go, people were completely comfortable offering chemotherapy without having muscle in the specimen. And as I said, in our own network, and I accept that I'm part of my network and therefore have influence here, we're sitting in our MDT every week looking at MRIs and saying, that's fine, they've got bladder cancer, it's clearly T3, let's get on with their treatment, don't go back and re-resect anything, just can delay the chemo they need.
We've had breakfast, we've had lunch, and now we're going to have the final dinner. And I'm really looking forward to Professor Bedke talking to us about the KEYNOTE 905 study. It's potentially practice changing, and it's really exciting. So you get the final presentation.
Yeah, no, thanks for the dinner words here. It's like in the cocktail reception. So no, I mean, I think, Nick, you made the first step doing the diagnostic towards muscle-invasive and also neoadjuvant therapy, which you mentioned. So let's talk about the KEYNOTE 905 or also the EV303 trial, which you mentioned, which was presented at the ESMO meeting some weeks ago. So actually, in 905, it's a perioperative concept which was applied using the antibody drug conjugate enfortumab vedotin plus the checkpoint inhibitor, the PD-1 antibody pembrolizumab, and I think this is important in cisplatin ineligible patients. Then these patients received cystectomy and again an adjuvant part of EVP for up to 1 year. So these are my disclosures being part of that trial, of course. So this is just the trial design once again. So please keep in mind it's cisplatin ineligible patients, and the ineligibility was defined by the classical Galsky criteria, and a minority of patients declined cisplatin who were also eligible to be included. So patients received the EV for 3 cycles in combination with pembrolizumab, then underwent radical cystectomy plus lymphadenectomy, and were then treated for another 6 cycles of EVP or pembrolizumab for up to 14 cycles, which sums up for 1 year. So you see on the slide that there was a third arm, or initially the first arm of pembrolizumab as a monotherapy, then followed by cystectomy and then pembro for the adjuvant part. This arm was stopped in November 2020, and the trial was switched to this combination of the antibody-drug conjugate EV and enfortumab vedotin. The control arm was standard of care, let's say, by that time, because in the cisplatin-eligible population, there's no defined neoadjuvant or adjuvant standard by that time, so patient had an observation. Later on, in the control arm, adjuvant nivolumab was allowed as a treatment option. So in total, 340 patients were randomized, 170 to EVP, 170 to the control arm. And it's quite interesting in looking at this patient disposition slide. So 156 underwent surgery. And the reason why they did not undergo surgery was either the major was withdrawal, only a few adverse events. And then the question is, how many patients started the adjuvant part? And of the initially 167 patients starting the neoadjuvant part, 100 went to the adjuvant part, of course, raising questions. I think if you see in a minute the trial results, do we need in this three-step process of neoadjuvant, second step cystectomy, third step adjuvant, all these three steps all together? So have a look at the baseline characteristics. So patients were old age, 74, between 72 74. There were a certain proportion of patients of ECOG2, and the ineligibility was about 33 to 80%. So eligible for cisplatin, but a declining 16 to 20%. And the majority of the patients had a T3, T4 tumor. And yeah, I'm very glad, Nick, that you mentioned this imaging, because the classification, the staging, the grouping to T3, T4A was based not only by TURBT specimen, but also by the imaging, which was independently blinded, assessed. The primary endpoint was event-free survival, independently assessed. And here we have a hazard ratio of 0.40, narrow confidence intervals, the medians not reached for EVP. In the control arm, about 16-month event-free survival with this concept start of neoadjuvant therapy. You see the curves are splitting early at the beginning. The delta stays stable, and at the 2 years time point, 74 patients are event-free with EVP in that setting. If you look into the subgroups, I think it's quite easy. It's more or less all on the left side favoring the combination of EVP in comparison to the control. There's no difference with regard to the PDL score, nor to the tumor stage, and maybe of interest to the creatinine clearance. And now if we look at the overall survival, and you know that patients with muscle-invasive bladder carcinoma are at a high risk of death. Here for the overall survival hazard ratio was 50%. So that means a 50% increase of overall survival with the combination of EVP. And again, the curves start separating early, so the green curve of the EVP. And the survival rates, it's not bladder cancer specific survival, it's overall survival in total 80% after 2 years. Now, if you look at the pathological complete response, or the so-called PATH-CR rate, and you learned that from Benjamin in the Sunrise 4 talk, that the PATH-CR is of interest. And with 3 cycles of EVP, we had a PATH-CR rate of 57%. So that means at the time of cystectomy, 57% of the patients had no residual tumor present in the cystectomy specimen, compared to 8.6% in the control arm. You know that also patients having had a TURBT, that this could have been a complete TURBT, having no tumor present at that time of cystectomy, and the absolute difference nearly 48% between EVP and the control arm. If you look at the events-free survival now by the PATH-CR status, I think it's logic that patients having a lower tumor burden or no tumor burden at all of the PATH-CR, that of course the event-free survival is the most beneficial. Event-free survival is achieved when patients having a PATH-CR, here 87% with EVP, if compared to the control. So even patients having a PATH-CR in the control arm have a lower event-free survival rate if compared to EVP. Of course, now questioning the benefit of, let's say, targeting minimal residual disease either by neoadjuvant treatment or by the subsequent adjuvant treatment here in this setting. What about the adverse events? You know that EV enfortumab vedotin plus pembrolizumab has an event rate of grade 3 for adverse events in the metastatic setting of immune-mediated adverse events by the pembrolizumab, but of course, class-specific side effects with the antibody-drug conjugate enfortumab vedotin, neuropathy, diabetes, which could occur. I think this slide shows us one important message, that in the surgery phase only, the adverse event rate with EVP was lower with 29% if compared to the control arm. I think this is somehow mirroring the tumor burden, which obviously has an impact on surgical morbidity. If that is lower, achieved, remember the 57% path CR in the EVP arm, this obviously translated to a lower serious adverse events rate in the surgery phase. What about all phases of treatment? Just to mention the side effects, 49% in the control arm, 71% in the EVP arm, just you split up by the side effects. And of course, you have the side effects or the surgical safeties, the surgical events which happened. What about the surgical phase? I think in the control arm, it's quite of interest that we have the classical surgical morbidity, which was observed, like the urine leakage, abdominal pain, nausea, urinary tract infection. Also, and this must be a little bit maybe careful, prostate cancer and incidental prostate cancer is one aspect when you do a cystoprostatectomy, and the patient was here also considered as monitored as an adverse event. What about the special interest with EVP? Just to mention them, of course, the skin reaction, neuropathy, ocular disorders, there was nothing new. Everything was in the range what was expected. And what we also know, compared to the metastatic setting, that the absolute rates of grade 3 adverse events were lower in this non-metastatic setting. So just one word now to the ctDNA and the clearance. And we talked about urinary DNA and clearance. Nick James mentioned the IMvigor11 trial. We learned from the IMvigor10 trial that patients being ctDNA positive receiving an adjuvant checkpoint inhibitor could be cleared to ctDNA negative status and then have a better outcome. And this was also proven in the so-called Tombola trial being presented at last year's ESMO. Here, patients underwent a serial ctDNA screening, and we observed that patients being ctDNA negative have a better outcome and an overall survival, recurrence-free survival, and overall survival. Questioning, of course, if these patients need an adjuvant therapy if they are ctDNA negative. And we learned that from the Niagara trial, and just to inform you and remind you, Niagara was a trial with gemcitabine, cisplatin, neoadjuvant cystectomy, followed by observation, or gemcitabine, cisplatin plus durvalumab, the PD-L1 inhibitor cystectomy, and then durvalumab in the adjuvant setting. And patients having a path CR being ctDNA negative still tends to have a recurrence of their disease. Questioning, of course, do we need these patients to be treated in the adjuvant part, even if they are ctDNA negative? And we learned here, and Nick, you presented that the slide, the data from the IMvigor11. The data from the IMvigor11 actually shows us if a patient is ctDNA negative positive or turns from a ctDNA negative status to a ctDNA positive status. And maybe this is the next step in the Bladder Path, the diagnostic pathway, to incorporate the ctDNA and the serial analysis of the ctDNA status. If patients receive an adjuvant immune checkpoint inhibitor, that they of course have a better overall and recurrence-free survival, because the ctDNA positivity can be converted to a ctDNA negative status. And this is the data which was presented at last year's EAU meeting from this IMvigor11 trial. I think this is of importance because if a patient is ctDNA negative, it very well correlates with an excellent overall survival. So let's now just sum up and finish. The perioperative therapy in MIBC has a new standard of care. I think for case of now, for the cisplatin eligible patient, as mentioned, it's gemcis plus durvalumab. What's new from the ESMO Congress this year is the KEYNOTE 905 EV303 data in cisplatin-eligible patients of enfortumab vedotin plus pembrolizumab in this perioperative setting. I think personally it's a new standard of care here, but we should not forget that cystectomy as well. And here I actually refer to the cystectomy because KEYNOTE 905 had cystectomy, while we also know that EVP trials of radiotherapy treatment modality are on its way, but it is still a cornerstone in this perioperative therapy. And in my opinion, the Path CR rate seems to be a good surrogate for an improved event-free survival and overall survival rate. And we all, I think, in our discussion later on, we would love to have the ctDNA on a regular clinical basis for our patients available. So I thank you for your attention here. Thank you.
Thank you so much, Jens. That was a brilliant presentation and a great way for us to take forward some more discussion. Just for everybody in the audience, it's great to still have almost 150 people still on the call. We are going to run, if that's okay, for another 12 minutes. So we're going to go with some questions. And I guess, Nick, Ben, I'll bring you in shortly, but Jens, staggering data and practicalities. As you said, eligibility for this was either they were ineligible for systemic chemotherapy, or they were ineligible, or they refused to have treatment. So in this patient group and in your practice now, do you have patients coming to you, or more patients coming to you, refusing to have the other treatment?
Well, it's an excellent question. So I think we must stress that KEYNOTE 905 was actually designed, and the majority, 80% of the patients were actually cisplatin ineligible. So I think the results of this trial should be grouped in the setting of cisplatin ineligible patients. And we should mention that for the cisplatin eligible patient, as of now, we got the EMA approval for GemCis plus durvalumab in that setting. We all know that there are other trials out there which may have a readout sooner or faster or later. The KEYNOTE B15, the same approach, EVP, in the cisplatin eligible patients, or the KEYNOTE 866 of GemCis plus pembrolizumab, or the Volga trial, which is on its way, and there's also a trial of nivolumab in that setting. But as of now, for today, counseling my patients, I think we should stick to the standard GemCis plus Durva if they are eligible. If they're ineligible, this definitely is in your treatment options. And in Germany, we are able to apply for that on an individual basis for the health insurance company to get access to these new drugs if they are already approved in that setting, in the approved for other setting.
Thank you so much for that really clear answer. So Nick, any thoughts from you?
Yeah, so one of the criteria for being cis ineligible is that you refuse cisplatin. So if I were a patient looking at these data, I would definitely refuse cisplatin. And we've been pointing this out to our patients in our MDT already and saying, do you want cisplatin, or do you want this treatment that's going to halve your risk of death? No, I don't want cisplatin. That's fine. Have VP Pembrose. And so as far as I can see, we can offer this to all of our patients now, and we've started doing it.
Okay. Benjamin, any thoughts or comments on practice?
Well, yeah, practice changing data, impressive results, complete response rates, amazing. And yeah, I think the problem that we are all going to face in the next coming months, and Nick already told it, is that patients come to our office and ask, I don't want to have cisplatin anymore. There is a better treatment there, and I just want to refuse it. So it's going to be a very tricky point in terms of reimbursement according to healthcare systems and everything, because there are a lot of questions behind it in terms of the economical, financial burden of EVP as well. But this is the best treatment we have nowadays, even cisplatin or cis ineligible ones. So I have this question. Of course, I mean, Jens also started to talk about it, but we will have a lot of question behind what do we do after progression in this patient that received EVP? What is the real benefit of the sandwich trial, especially for patients who have received, who are able to get durvalumab? Will they accept it or want to have EVP? And I think the last question remains, and we don't have a real answer, would be, I think a lot of patients will ask for a reassessment of their bladder before cystectomy. And for this patient who do not want to have cystectomy because they say, yeah, 57% we get a T0, I want a TURBT, and then we're going to discuss again. And that's going to be a very challenging time. I think it's moving so fast, and we don't have enough in any tools that are accepted in our daily basis to completely follow the patient wish. So that's going to be difficult to educate our patient that we have to follow the guidelines, that we have to follow the evidence, and it's going to take a bit of time to figure out how to do it.
Yeah,
Thank you.
I was going to say, as I put in my slide, I mean, breast surgery has gone from, very mutilating, large-scale surgery to essentially some, very small lumpectomies because the systemic therapies are so good. And this is absolutely transformational data.
And can I ask, I mean, Jens, you articulated really nicely a clear patient population articulation there, and we've heard discussions around this, but just talking again about frail patients, because it has been asked in the chat, and I think we all would acknowledge that we see a lot of people over the age of 80, for example, not being ageist, but are significantly frail with advanced disease. So any thoughts on that aspect of care? Do you think more patients are likely to be benefiting from treatment because of this data? And is there anybody you wouldn't offer this to, apart from the obvious contraindications?
Yeah, I think it's an excellent question for the clinical setting. So we all know that our bladder carcinoma patients are older than our prostate or kidney cancer patients usually, and that they seem to be more frail, specifically the cisplatin ineligible population. And I think it points towards the direction that you start with the EVP treatment in that setting. And if you achieve a path CR, of course, it's questionable if these patients, if they are frail and you are in doubt if they are eligible for surgery, should receive, of course, then as subsequent next step, the cystectomy. So let's say it in these words, if you're in doubt if the patient is really eligible for cystectomy due to his frailty, for various reasons whatsoever, I think we should check if the patient would be eligible for enfortumab vedotin pembrolizumab in that setting. It does not automatically mean if a patient is not suitable for cystectomy that he can receive systemic therapy, of course. Who is not eligible for systemic therapy here, specifically for EVP? I think it's absolutely a minority for patients who are not eligible for EVP. Of course, if you have had a severe polyneuropathy in the past, the classical, let's say, exclusion criteria for immune therapy, but we know that in the real world setting, severe autoimmune diseases and transplants are contraindications here to receiving an immune checkpoint inhibition. But it's very wide, and usually patients not being eligible for this specific regimen is very rare.
Thank you. Nick, any final thoughts or comments before we start running towards the close?
Yeah, so basically you already have the option in frail patients doing chemo-RT anyway, which has got a much lower death rate, frankly, than surgery in the over 80s. Yeah, we put 450 patients through chemo-RT as part of the BC 2001 program with no treatment-related deaths at all, and a median age in the mid-70s, 20% of the patients over 80. So you don't have to do surgery anyway, even with current technologies. But I think all of Jens's points are really well made. I think as the systemic therapies get better, the question of do you really need to operate on somebody with a pathologically clear bladder is going to get, or do anything else at all, is going to get more and more relevant.
No, thank you. Jens, any closing thoughts or comments about the data and what you've heard in the presentations today, or any top tips for those watching?
Well, keep your eyes on what's up in the landscape next year. And of course, you should all learn how to deal with our patient with systemic therapy in this approach, because we learn what to do with a path CR rate of 57%. So one of the new cornerstones is obviously also the systemic therapy in this neoadjuvant setting. And I think as a take-home message, we always had the discussion of neoadjuvant, adjuvant treatment. Now they have a perioperative setting, and it's of utmost importance that's also in the patient who are cisplatin ineligible, who were never sought to receive a systemic therapy upfront of cystectomy, that we now have new treatment option, who obviously had an absolute great overall survival benefit here.
Well, look, I'd like to say thank you to all of the speakers and the panel members tonight, and to the AEU for hosting this. So Prof. Nick James, Prof. Jens Bedke, and also to Benjamin Pradère, who's dropped off the call. Thank you so much. And to you, the audience, thank you so much for watching. And please put any feedback that you have about the session you've had to us. We'd love to give you more, but you've got to tell us that you like it. So thank you so much, and have a great evening, everybody. Goodbye.
Bye.